Afternoon. Welcome to today's Grand Rounds presentation. Please remember to fill out your attendance record, and also please remember to fill out the program evaluation and give us any ideas that you might have in regards to future topics or future speakers. Our speaker today is Dr. Jonathan Burns. Dr. Burns is board certified in emergency medicine and is a member of the Department of Emergency Medicine at Mary Greeley and McFarland. And he's here to help us make sense of the D-dimer and its use in diagnosing thromboembolic disease. So please join me in welcoming Dr. Burns.
Thank you. All right, thank you. Can everybody hear me okay? Way back there? Perfect, and the satellite sites are okay. All right, well, thank you very much for having lunch with me today. I'm Jonathan Burns, and I recognize most faces here. For those of you who don't recognize me by my face, I've been in the ER here and down at the pit for about 5 years now. Most of you who don't recognize me by my face may recognize me by my alter ego, which is usually when the pager goes off about 3 o'clock in the morning, and you say it's the ER again. That 2525*9 is also how some of you may recognize me as well. I usually, when I do a lecture like this, I usually start with a really cool slide, a recent trauma or a neat x-ray or an EKG or the helicopter taking off or something that shows my perspective of what I think about the ER. But I recognize that a lot of you have a perspective that's more along the lines of this. And that perspective is okay, because when we talk about testing and when we talk about D-dimer and when we talk about the workup of venous thromboembolic disease, perspective is important because it's a controversial topic top to bottom. So I want you to know that although your perspective may be like this, that's okay, because my mom still sees me like this. And that's good to know, because I've been told my nurses see me this way. And in the perspective of administration, oftentimes they see me this way. So even though I started with that first slide, I still want you to know that when I come to work, I still see myself like this, even if my wife sees me like this. So right off the bat with the disclosure, I have no financial obligations or relationships or conflicts of interest right off the bat. The presentation that we talk about here today relies on the best level of evidence that we have out there. The only thing that I will mention by name is our D-dimer assay that we have here, which is the Dade-bearing advanced D-dimer, only because I think that's most pertinent for our patient milieu to talk about that particular device that we're all using here in the clinic and the hospital. Everything else that I talk about relies on the best level of evidence and the best literature that's out there, and there's a lot of literature that's out there. I need to, before I forget, towards the end, thank Lori and Emily, our medical librarians. I think over the last couple of months I requested something on the order of 60 to 70 articles for this short presentation to review. And if you're getting an article from like the New England Journal from the last couple of years, it's not too hard, but to really go back and take a look at the root literature associated with, you need to go back 30, 40, sometimes 50 years, and they were able to find all of these articles for me. So a big thanks to them. And another bias that I have right off the bat, I'll tell you, is that I have a personal bias. We talked about perspective. I'm a big fan of Dr. Jeff Klein, who I think is really the most preeminent researcher in the field of venous thromboembolic disease today from the Carolinas. We'll talk a lot about the literature and research that he's done lately, as well as Dr. Newman and Weingart, who've really done a good job of synthesizing a lot of that data that's out there. One more disclosure that I have and one more bias is that I really like testing. And so it's good to have an ER doc do a presentation like this, because we all like testing. And that's good because it makes us happy. We like tests because the right test can give us the right answer, but intrinsically, we know that it has to be the right question that we ask, and it has to be the right test that we order. And that's where something like the D-dimer gets a little bit more challenging. But we like tests because they make us feel good. For example, if I do a test like an EKG like this gives me an answer. It tells me what I need to do next. An X-ray, a test like this, once again, this gives me an answer. And it tells me what needs to happen next. So we like those tests. And it could be something as simple as a binary test, like a pregnancy test, that tells us a yes or no answer and allows us to proceed forth a little bit further. So we like testing because it makes us feel good, but what we don't like is a test like this. And here's a chemistry panel from a patient from several months ago, and you can see it's relatively straightforward except for some renal insufficiency there. But then we have this right here. We've got a D-dimer of 0.52, and a lot of us have been in this scenario before, where we have just above the cutoff. Our cutoff here at this institution is 0.50 milligrams per liter. So we have a positive D-dimer in the face of somebody with renal failure, and we say, crap, I don't want to CT this guy, I don't want to image this guy. And so the purpose of the lecture today is going to be how can we avoid getting to this situation. So the objectives, we have to talk a little bit about some of the obligatory pathophysiology and epidemiology of what's going on with this. But everybody in this room, for the most part, has been there, and we don't need to go in very much detail there. Well, the meat of the brief lecture we want to spend is talking about diagnostic strategies. There's really three of those. Of course, our D-dimer. Of course, our clinical decision-making rules like PERC and Wells and the modified Geneva score, but also physician judgment. And we want to take a look at the literature or the evidence behind those three criteria. And then what we'll try to do by the end is build an algorithm that's based on that evidence, which at the end of the day should prevent situations like that, should be easy, it should be safe, it should save radiation, it should be better for our patients, for our conscience, for our brains, for our radiology colleagues who have to read all these unnecessary CTs. So it should help us out top to bottom. So that's what we want to get to today. So really quickly, that obligatory pathophysiology, everybody remembers Virchow. We've been there before. So we know it's a disorder of the normal clotting cascade. We get thrombosis, or we get an embolic event that ends up in the blockage of the pulmonary arterial vasculature. Now, what about incidence? And incidence is important when we talk about epidemiology because that helps us understand the fatality and the lethality of pulmonary embolism. So two interesting studies going back to the 60s and 70s are interesting. A study by Freeman back in the 60s actually took a look at 61 consecutive autopsies where they did microscopic dissection of the lungs and found that of those patients, 64% of those had PE. And more interesting, there was an 85% non-association rate, meaning those patients who died did not have pulmonary embolism associated with their death. They didn't have an underlying malignancy. They didn't die of PE. And a study that was repeated in '77 in Scandinavia took a look at 500 random autopsies and found within microscopic dissection there, they had a 70% prevalence of pulmonary embolism, a 50% non-association rate, and of those 500 autopsies, 20% of those were traumatic or accidental deaths. These were people who, at the time that they had their autopsy study done, were walking around possibly with some clot burden already on board. So it may be that the incidence of pulmonary embolism is a lot higher than we've thought beforehand. And it may be actually that we carry some microscopic clot burden one way or another, only because if we didn't have our lungs to filter those out, where would they go? They would go to the heart, they would go to the brain. So these studies initially showed a higher incidence than thought. That's important because when we look at lethality, a lot of these studies, which have been sort of misunderstood, were used to talk about pathology. And the Alpert study, which was done in '76, which when you go through all the American Heart Association, the American College of Chest Physicians, even the American College of Emergency Physician guidelines, all reference this Alpert study as the mortality of missed PE being 30%. And it's not a study, it's actually an editorial. And they don't cite their data where they got this. They go back to some of these sort of misunderstood autopsy studies and came up with, they believe there was about 3,000 missed PE and about 1,000 of those went to die. So they said, well, about 30% of these missed PEs are going to die. And it wasn't until about 6 years ago when Kristen Calder, Mel Herbert, and Sean Henderson out of USC actually took a look at that data and applied statistical analysis to that. They found the actual rate of fatality somewhere around 5%. And when we've gone through and actually done post hoc analysis of some of the other bigger data sets out there, the Wells group and the PERC validation study, it does end up being that the mortality is not 30%, which is suggested in all of the major position statements. It's more likely under 5% as well. So it's important to understand both the incidence is probably higher than what we suspect, but the mortality, the lethality of this, much lower. So now that we understand a little bit about that, we can actually talk a little bit about how to make that diagnosis and talk about signs and symptoms that are predictive of PE. These are referenced several times in the textbook. The best recent study comes from the PERC validation set by Jeff Klein. This was about 8,000 patients all enrolled in a pulmonary embolism study set, which we'll talk about in a little bit. But what Jeff Klein did is post hoc analysis of his own data to take a look at what the signs and symptoms that got these patients enrolled into this PE data set looked at. And he divided this up into both explicit criteria and implicit criteria. Those explicit criteria being things that have been studied already, so things that we knew about were in the literature, and implicit criteria being things that we've been told that we thought we knew but really haven't been studied at any length. And what he found is really not surprising. If you calculate the odds ratio out, the most common risk factor within this validation set was to have had PE or DVT in the past. So if you have a history of venous thromboembolic disease, you are more likely to have PE with an associated odds ratio of about 2.9. Now those numbers go down a little bit. Unilateral leg swelling is also up there. Any concomitant estrogen use or active malignancy as well as hypoxia also increased that risk when he did that regression analysis and calculated those odds ratios out. The implicit risk factors are a little bit more interesting. Pleuritic chest pain has an odds ratio of about 1.5%, but within this validation study, if your pain was sudden onset or you were postpartum, that didn't significantly increase your risk of having PE. And actually, if your pain was substernal in nature, or if you were a smoker, in this subset here of patients that had already been enrolled in that data set, they had less likelihood of having PE. Why? Because they probably already had something else. They had coronary disease or COPD as a cause of their discomfort as well. So now, most important when we take a look at this, we know a little bit about the incidence, the prevalence. We know a little bit about how to diagnose it. How do we stratify that risk? And there's really three ways we can stratify risk in venous thromboembolic disease. When I say VTE in this situation, I'm really talking about D-dimer, or about PE. Talking about a DVT is a little bit beyond the scope here. But how do we stratify risk? There's three ways to do that. There's plain old physician judgment. When you walk in the room and you look at this patient and say, I think they have a PE, how good are we? There's, of course, laboratory testing, what we're all here to hear about, which is the D-dimer. And then to help us a little bit, there's some clinical decision-making rules and guidelines like Wells, like the modified Geneva, and of course PERC, which we'll talk about a little bit as well. So to start with, physician Gestalt, how good are we at diagnosing PE? Pretty good? Terrible? The answer is we actually really did learn something in medical school. When we actually take a look at a patient and say, I think they do or don't have a PE, we're actually pretty good. And there was 5 good studies that took a look at this. Probably the best of those and the most adequately powered was the initial PIAPED study, where they actually took a look at patients with PE and they were patients in this subset, and they asked physicians beforehand to rank the likelihood that each patient had a PE on a scale of 0 to 100, just based on their initial input, their Gestalt, and their examination. No guidelines or criteria with this. And for those patients which were classified as unlikely or less than 10, they had about a 9.2% risk, or a 9.2% PE rate for patients that were considered moderate or scored 20 to 60, about 29.9%. And those physicians that scored their patients above 60, there was about a 67.8 association rate. And that's been validated externally as well in the Runyon study and in the Sanford study, who compared physician Gestalt in addition to Wells. And it turns out that for the most part, we're pretty good when we look at a patient and say, I think this patient does or does not have a PE. So in terms of Gestalt, we're actually pretty good. Now what about D-dimer? Well, this is something that we all kind of intrinsically know was not the test that it was made out to be initially. The D-dimer is a fibrin degradation product, so we know it's present after fibrinolysis. Therefore, the thought is that there has to be clot present. The coagulation system has to have been activated, and D-dimer has to exist somewhere in the setting of thrombosis. So the initial really good utility for D-dimer is, well, if there's a DVT or a PE present, your D-dimer is going to be elevated because there's clot present. Or if you're in DIC, you can measure this as an FDP as well in DIC. So there's two utilities for this. But the major purpose of this was that it was developed to decrease the use of CT and decrease the use of imaging for suspected PE. Now, our test that we have here is the Dave-Bearing Advanced D-dimer assay. That's now with Siemens, by the way. I think they got bought out. And the package insert that was provided to me from Connie shows a sensitivity and specificity of about 98 and 38% respectively. So a very good negative predictive value of about 99%. The only independent study I could find was the Gosselin study, but the numbers correlate pretty well. So it's a good test. It has good sensitivity, which is what we need for a good negative predictive value with that 99%. So it helps us suggest that if we have a negative D-dimer, that's pretty accurate right there in ruling out a PE. Now what if we have a positive D-dimer? Well, there's the problem, because you can see those specificities of 38 and 43% respectively mean that you'd be better off flipping a coin than using a D-dimer to try to diagnose PE. So really what we have is half of a test. We know if it's negative, it's encouraging. However, if we have a positive test, it doesn't mean much at all, and that's a problem where it's been misused a little bit. So the question is, has the D-dimer done what it's been set out to do? Has the D-dimer decreased the use of CT imaging in PE? Of course not. But conversely, has the use of D-dimer helped us diagnose more PEs? And the answer, unfortunately, doesn't help us out. The handful of studies out there have showed that CTs have markedly increased. Now, the use of CT imaging across the board has gone up quite a bit, but the CT in the era of D-dimer has increased. But in the handful of studies that have taken a look at it, the diagnosis rate has remained the same. So we're imaging more people, we're subjecting more people to the harms of radiation, but we're not diagnosing more clots. We need to do things a little bit differently. Why isn't D-dimer good? Well, there's a lot of false positives. Everybody here knows this. You can be pregnant, you can have malignancy, you can have a fall, you can have trauma, you can have rheumatologic issues. All of these things can cause false positive D-dimers. But oftentimes the D-dimer is ordered without a thought of pretest probability. And that's important. We're not asking ourselves, are we ordering the right test, or are we asking the right question? Now, what I mean by that is if we look at somebody with very low pretest probability, we have here on the right, we have Dr. Salama, who looks like he's doing something very important. And the question we ask ourselves is Dr. Salama pregnant? What's our pretest probability for Dr. Salama being pregnant? It's pretty low. So does a positive pregnancy test for Dr. Salama mean that he's pregnant? No, it's a useless test in the setting of that very low pretest probability. Now, you guys can make some argument, you could have some sort of germ cell malignancy, I guess, but for the most part, it makes no sense to order this test in somebody who has a very low risk of disease. And conversely, if we have this patient that comes in and they've just gotten off the plane from Australia and they're coughing up blood and they're hypoxic and they've got substernal chest pain, is a negative D-dimer useful here? Well, to some degree, yes. But in the setting of a very high pretest probability, it doesn't help us as much. So what we need is a way to use the D-dimer appropriately, to be able to frame that so we can ask the right question. And the best way to do that is clinical decision-making rules. And I want to talk about two of those right off there. The one that we're all most familiar with is the Wells criteria for PE. And this is a scoring system that categorizes patients into likelihood or risk of pulmonary embolism. And the Wells data set has been externally validated several times. It's a good study, top to bottom. What I want to talk about is why these numbers here may be a little bit different is I took a look here at the outpatient data sets only. The initial Wells group is about 80% inpatient, 20% inpatient, or 20% outpatient studies. But we took a look at the outpatient data set here because this really is most pertinent for what we do here. When you start to use inpatient studies as well, those numbers seem to kind of go up by a factor of about 3. But for the most part, in those outpatient studies using Wells, if you have a low-risk Wells score, or 0 to 1, based on those criteria to your right, your likelihood, your risk of PE is about 1.3%. A score of 2 to 6, or moderate, puts you at a risk of about 16.2%, and any score higher than 6 puts you at a likelihood of about 40.6%. And that's been validated in a couple of different studies as well. Now, what about the PERC rule? Now, the PERC rule is the pulmonary embolism rule-out criteria, and a lot of us in the last 3 to 4 years in the ER have been using PERC quite a bit. So you may see this in some of our notes when we write about patients. And PERC is, when we talk about controversy and we talk about perspective, if you really want to get two academically minded emergency doctors in a fight, bringing up PERC is a good way to bring this. And PERC was a study that was developed by Jeff Klein, and it's different than the Wells criteria for a couple of different reasons. Number one, it's not a scoring system. It's a series of criteria that all have to be yes in order to be PERC negative. We'll talk about that. But number two, when Jeff Klein developed the PERC criteria, he didn't do this to try to absolutely rule out all the patients with PE. What he did was first establish a test threshold. And this is based on a great 1980 paper by Pocker in the New England Journal of Medicine, which actually tells us what's the prevalence of disease that you're testing them for, where the benefits of testing outweigh the harms of testing. Or another way to put that is the test threshold is at which point do we do more good than harm by testing. If we fall below that, we're going to cause harm to patients if we test everybody. For example, we could order a D-dimer on every single patient that came into the emergency department, and we would miss very few PEs. But we would cause tremendous harm by all the additional radiation and exposure, and we'd probably get beaten up by the radiologists for all the initial CTs that we obtained there in the meantime. So the test threshold is a way to calculate that out and figure out what the prevalence of this disease is below which we test everybody, or I should say where we cause more harm than good if we fall below that. Now every presentation should have a slide that nobody understands. And so I put this in here right away. But this is really how Jeff Klein calculated this. But really, if on your evaluation you have a box to check that, did he have a slide that I didn't understand? You can check that box yes right now, because nobody understands it. But that's how he took a look at this. And what he came up with was a test threshold of about 2.0%, using the risks of testing, or what would happen if we tested everybody. So what are the risks of testing somebody for PE? Well, of course, we know, particularly in the Brenner paper that came out in 2007, but even some papers that came out with the CT head out of Lancet a couple months ago, we have a huge risk of unnecessary ionizing radiation. The Brenner study suggesting 2% of all future malignancies could be associated with medical radiation. We have risks of contrast-induced nephropathy, extravasation, anaphylactic reactions, and in particular, also risk of false positives. The most recent study, the Weiner study, in 2004, which really took a look at the current generation of CT scanners, still is only able to show an accuracy rate of about 91%. So we have false positives, and we have all the associated risks of somebody walking around getting heparinized and then being on warfarin for the next 6 months. So those risks were all calculated into that prior study, and the test threshold comes up at right about 2%. Based on that, Dr. Klein was able to put together the pulmonary embolism rule-out criteria, and those are the 8 criteria that you see in front of you. And if all of those are true, meaning the patient is PERC negative, they fall below that test threshold. So if your age is less than 50, if your heart rate is less than 50, if your oxygen saturations are less than 94% on room air, there's no prior history of VTE, no recent surgery, hemoptysis, no exogenous estrogen use or unilateral leg swelling, and your pretest probability is less than 15%, your likelihood of having a PE at 45 days is 0.9%, well below the test threshold, and the risk of any DVT or PE still falls at 1%. That still seems like a high number. We're missing 1 out of every 100, but it's important to look at when you actually take a look at the PIAPED studies, when they actually took a look at their patients 90 days, everybody who had even had studies performed going back through PIAPED, through the Kazmaier study, and also through the PERC validation study, patients that had had gold standard studies involving pulmonary angiography, their risk of PE at 90 days was still, in some studies, up to 1%. Which goes to show you that if you're high risk for PE to begin with, you're still going to be high risk for PE even if you've ruled out. So those are pretty good numbers based on the PERC criteria and the PERC guidelines right there. So now the question is, as we move forward, can we put together an algorithm using everything that we've talked about so far? And the answer is yes. The one really good study that took a look at this, which was an excellently powered study of 3,300 patients, which is a Christopher study, took a look at selective use of D-dimer and the Wells criteria together. And instead of taking low, medium, and high risk, they made it a binary group. Those that were 4 and under were low risk, and above 5 were high risk, and found that of those patients who were low risk, 4 and under, they all had a D-dimer performed. If that D-dimer was negative at 3-month follow-up, and as D-dimer negative low-risk patients numbered at just over 1,000, they had no deaths at 3 months with only 4 PE for an incidence about 0.4%, or well under the test threshold there. Those high-risk or D-dimer positive patients went right to CT afterwards. So based on this, here's the algorithm that I put together that I think allows us to use this in an evidence-based study and help us out quite a bit. This is loosely based on a similar algorithm by Scott Weingart, but I've changed things a little bit based on what I saw in the literature. And the first question is, do you think the patient has a PE? If they fall into this group of, yeah, do I think they have a PE? And I think they have less than 2% of a chance of PE. They fell down and bruised their chest, and that's why they've got pleuritic chest pain. They've already fallen below the test threshold. And we know that clinician Gestalt has been shown to be pretty good. So we can stop our workup if we think there's less than 2% chance. On the other hand, if this patient did come over, they've got a big swollen leg, they're coughing up blood, they just got off the plane from Australia and they're hypoxic, we don't need to go through any testing. Their likelihood is high enough that we can go right to treatment and we can go right to diagnostic imaging at that point. But what if we're in the middle there? Then you ask yourself again, do you really think they have a PE? If you're somewhere in that 2 to 15% realm, do you really think, well, maybe less than 15%, at that point you can apply PERC. And if that patient is PERC negative, they're once again under that 2% test threshold, and you can stop the workup. If they're PERC positive, let's say they have a heart rate of 110, but otherwise things look good, then we can drop down and apply the Wells criteria. And I think based on the Christopher study, if they're Wells low risk, remember, that puts them at a 1.3% risk of PE, or below the test threshold. We can stop the workup there. If they have a Wells score of higher than 6, then we can proceed forth to imaging at that point, and then only in those PERC positive Wells moderate risk criteria. Can we obtain a D-dimer? Based on the Christopher study, we know if that's negative, we fall well below the test threshold. We can stop our workup, but if it's positive, then we can proceed forth to imaging fairly confidently that we've done everything right so far. Okay, so I'll stop the lecture there because I want to take time for questions and everything like that. I think it's worthwhile, based on everything that we've talked about, just to talk a little bit about what the future holds. There's so much good evidence out there, and really in the last couple of years, a lot has come out recently. It would be worthwhile, I think, based on what I see, how we treat PE and VTE in the next 5 years is going to be a lot different than what we've been doing for the last 15 or 20 years. A couple of studies by Jeff Klein that have been recommended. Can we use D-dimer in pregnancy? Yes. And Jeff Klein, although he doesn't have the adequately powered studies, has anecdotally suggested we can increase the D-dimer positive by about 50% per trimester and actually get away with diagnosing more patients and saving that radiation, meaning that for the first trimester in our lab, we'd be able to go up to 0.75%, up to 1.25 milligrams per liter in the third trimester. The use of sliding scale D-dimer is currently in press. That's due to be published in the Journal of Thrombosis and Hemostasis. Suggests that we should be able to massage our D-dimer cutoff based on the patient's risks one way or another, which should be an interesting study as well. We'll of course be saying goodbye to warfarin. There's newer anticoagulants out there. We already have a dabigatran as a direct thrombin inhibitor for AFib. And we also have, coming down the pipes, we have rivaroxaban, which is FDA approved right now as a factor 10 inhibitor, and also apixaban, which should be coming down the pipe too, as oral anticoagulants, which will not need to be measured, and are at least non-inferior and arguably safer than Coumadin, although we'll see where that actually pans out. And finally, there was a study that came out in Lancet a couple of months ago that took a look at patients that had been admitted in Europe, and they found that about 30% of those patients that had been admitted for PE could be safely treated as an outpatient. And because we have these agents here coming down the pipe, that may be something that we're doing in the future, is possibly diagnosing somebody with PE and sending them home with a pill. Because of that, there's new developments on the PESI score, Pulmonary Embolism Severity Index, and some consideration towards outpatient management, although that makes me nervous. And then finally, all three major associations, the American College of Emergency Physicians, the American Heart Association, the American College of Chest Physicians, have all put out guidelines. They're all 2C kind of based guidelines right now and recommendations for use of thrombolytics and massive PE, those that are associated with hemodynamic instability, and some recommendations for submassive PE, those where they're hemodynamically stable if there's evidence of right heart strain. There may be some use of thrombolytics there as well. Okay, so I'll take any questions here and let you go a little bit there, but whoop, I'll go through references here. A lot of references here to take a look at here, and I'll take any questions if you got them. Jay's got one.
I just saw something in Journal Watch yesterday about age and D-dimer. Thoughts on age and D-dimer?
Exactly. So the question is age and D-dimer. So as you get older, the sensitivity and specificity goes down as well. So D-dimer is kind of half of a test. Unfortunately, there's a lot of things that can cause those false positives, and unfortunately, advanced age. I think I saw that too. And is that the one you're talking about? As you get older, the D-dimer becomes less useful as well. So it's another sort of a bad situation to use that as well. So another one, when you take a look and actually look at your pretest probability, age is also one of those things that can cause false positives as well. Anything else? All right, guys. Well, thank you so much for having lunch with me today, and I hope it was kind of useful.